Good morning. This is Maisha Burke from New Jersey Department of Health, and I'd like to welcome you to our webinar, Managing Zika Testing Requests for Local Health Departments. This webinar is put on by our New Jersey Department of Health Regional Epidemiology Program, also working along with the Zika team. First, I would like to go over some housekeeping recommendations for this webinar. During this webinar, we will refer to documents that should have been emailed to you last week by your regional epidemiologist, as well as distributed via link messages. We have also included attachments in this webinar of the 5 main documents that we will review during the webinar. In order to efficiently use our time and answer as many questions as possible, we will be answering all questions at the end of the webinar. Questions can be entered into the question box or chat box at any time during the webinar, but we will respond to those later. To go over an agenda of our webinar, the things we will review are testing criteria and the approval process overview, an intake process for Zika testing, as well as provider counseling, CDRSS entry and approval numbers, SRD1 form completion, mock scenarios, the resources, and Zika updates. As many of you know, that the Regional Epidemiology Program has been working together with the Zika team since January 2016 to manage the Zika approval and testing process for the state of New Jersey. While initially there are many limitations and changes occurring to refine the Zika testing process, we were able to outline definite steps to take for Zika approval. With the steps in place and now being able to test at FEL, then we are now asking for assistance from local health departments in processing Zika testing requests. Although there are steps in place, then we must let you know that there may still be changes to the testing process or even the criteria for testing as more information is discovered about Zika virus disease. Any updates will be distributed to you via links message. The purpose of this webinar is to educate the local health department staff on Zika testing approval. Effective July 20th of 2016, the New Jersey local health departments will begin providing Zika testing approval for residents. The New Jersey Department of Health recommends that the testing of patients be done during normal business hours. You will help the providers determine patient eligibility, share Zika prevention information with the provider, complete documentation for those approved, and send the documentation to the provider. Local health departments are expected to work with providers to process testing approvals, and the provider should be the one to collect the information. So let's look at the roles between the provider versus the local health department. So the local health departments will collect information from the provider, determine testing eligibility, advise the provider to counsel the patient, enter the approved patients into CDRSS, where they will get an approval number, and provide an SRD1 form to send to the provider, as well as a fax cover sheet and the cell technical bulletin. The provider will collect patient information and counsel the patient on precautions. They will supply testing documents to the patient, coordinate the specimen collection of the patient, inform the patients of results, and follow up on patient care. So what if the patient calls the local health department? Local health departments are only expected to work with the providers in regards to testing, so patients calling about testing should be referred to their provider. If a patient calls with general questions regarding Zika testing, then they should be able, if the health department cannot answer the questions, then they should be referred to the New Jersey Poison Information and Education System, otherwise known as NJPIES, at 1-800-962-1253. This line is staffed 24 hours a day, 7 days a week, 365 days a year. The hotline is able to answer questions from the general public as well as healthcare providers, and they also have the ability to answer questions in any language. So what if the patient resides outside of my jurisdiction? So if the patient is outside of your jurisdiction, then the local health department can do one of two things. They can either process the request if they're able to do so or they can send the request to the jurisdiction in which the patient resides. If the patient resides outside of New Jersey, then you can either process the request if possible, which we would greatly appreciate, or you can send the information to the New Jersey Department of Health for processing. So moving into the actual testing criteria and looking into Zika testing approval processes. And looking at the testing criteria, we hope to answer who should be tested, what are the symptoms, when should they be tested, where do they get tested, and how is the approval process completed. So who should be tested? Anyone, that includes any adult, children older than 2 weeks, pregnant and non-pregnant women who has at least one symptom of Zika, who within the past 2 weeks traveled to a Zika-affected area or had unprotected sex with a male partner who traveled to or resides in a Zika-affected country. All pregnant women, symptomatic or asymptomatic, who during the 8 weeks before conception or at any point during their pregnancy traveled to a Zika-affected area or had unprotected sex with a male partner who has been diagnosed with Zika or has symptoms of Zika after travel to a Zika-affected area. Please refer to your Zika virus testing approval flowchart included in your handouts and also sent to you last week, which we will discuss later for specific time frames. For any other situations, such as if you are unsure if the patient meets testing criteria or if there's a novel mode of transmission suspected, such as local transmission, congenital transmission, or blood transfusion, collect the patient information from the provider and call your regional epidemiologist for a consultation. We can always be reached at 609-826-5964. So what are the symptoms of Zika? You need at least one of these symptoms here that are listed. The most common signs and symptoms listed below are fever, rash, joint pain, or arthralgia, and conjunctivitis. These are the symptoms that we are looking for in testing. Try to document the temperature of the patient and the type of rash and distribution if possible. Please make sure to document any other signs and symptoms exhibited by the patient also. When should they be tested? If symptomatic, they should be tested within 2 weeks from the last exposure, which would be 2 weeks from travel or 2 weeks from the unprotected sexual intercourse with the symptomatic male or male diagnosed with Zika. Or in pregnant women, those who currently have symptoms or were previously symptomatic should be tested as soon as possible. Or asymptomatic pregnant women should be tested within 2 to 12 weeks from their last exposure. Note that if a woman traveled more than 12 weeks ago, then she should be denied from testing, as the testing is not reliable after 12 weeks due to possible weaning of the IgG over time. Once again, this is another place to look at your Zika testing approval flowchart, where it will come in handy. Where do they get testing? So it's required to be tested it's required to have specimens drawn at a hospital laboratory in order for PHEL, the Public Health Laboratory of New Jersey, to do testing. Why a hospital lab? The hospital lab is familiar with the submission of specimens to PHEL. This will prevent specimens from being returned due to improper collection, processing, packaging, or shipping of specimens. For those unable to use a hospital lab, here are some suggestions. Discuss if the patient has charity care at a facility, or call your regional epidemiologist. I might want to add that also that in regards to Zika testing, there is no fee for testing. However, there may be fees that the hospital charge that are associated with the drawing of the specimen. So how is the approval process completed? It is recommended that process requests are only conducted during normal business hours. Determine if the patient is eligible for testing through reviewing pregnancy status, patient's exposures and symptoms, if any, against the LHD Zika approval flowchart. You can use the tools, the LHD Zika virus testing approval flowchart, the NJDOH information website, and other resources. And then follow the steps. Follow the Zika testing approval process that we'll go over shortly. So here's the Zika testing approval process. To go through the steps, you will determine the eligibility of the patient for testing using the Zika virus testing flowchart. which is attached in the handouts once again, and then collect the patient information. So first you want to know, does the patient meet criteria? If not, then you will still advise the provider on counseling the patient for prevention. If so, then gather the information. That is where you can use the Zika virus patient information worksheet. Next, you'll advise the provider still on counseling of the patient regardless of whether or not the patient meets the criteria. You'll create a case in CDRSS, which will then provide you a part of the approval number that we will review later in this presentation. You'll complete the SRD1 form, and then you'll send the SRD1 form and the New Jersey Cell Technical Bulletin to the provider. Now I would like to talk about tools to help you quickly determine whether a patient is eligible for testing. So, New Jersey Department of Health has created 2 flowcharts for testing approval. Chart number 1 that we'll go over is for the testing of pregnant women, and the second chart is for the approval of all other individuals. Notice that there is not a flowchart for children under 2 weeks of age. For children under 2 weeks of age, you'll want to contact the New Jersey Department of Health. So looking at the chart for pregnant women, you can see that the chart starts with whether or not the patient meets the criteria for exposure. So let's review the exposure criteria for pregnant women. So we want to know if within the last 12 weeks, does the patient meet this following criteria for exposure? 1, that they travel to a country with Zika transmission, and you can see the link here that will show you all the most recent countries updated by the CDC. Did they travel while pregnant or in 8 weeks prior to conception? 2, did they have unprotected sexual intercourse, whether it's vaginal, anal intercourse, or fellatio with a symptomatic male, or who had traveled to a country with Zika transmission anytime during pregnancy or 8 weeks prior to conception. And then the third is where you would call your regional epidemiologist. If there's other or novel or fetal anomaly detected at any time after an exposure during pregnancy. Next, you'll look into if the patient has symptoms or not. So if you're looking at the chart next, then you'll look at the chart and see if the patient has symptoms. So if the patient is asymptomatic, then the provider should send the patient for collection at 2 to 12 weeks after the last exposure. If the patient is currently symptomatic, then you will send the patient immediately for specimen collection. Note that in the asymptomatic patients, the time frame is 2 to 12 weeks. An asymptomatic pregnant woman should not be tested any earlier than 2 weeks and no later than 12 weeks. Once you have determined the time frame, then advise the provider to counsel the patient on mosquito prevention and avoiding mosquito bites for 3 weeks from the last exposure, and also to prevent sexual transmission from a male partner who also had exposure by either abstaining from sexual activity or using condoms during the duration of the pregnancy. So let's look into our second chart. So looking into our second Zika virus testing approval flowchart for men, non-pregnant women, and children older than 2 weeks of age, once again we'll look into the exposure criteria, and we'll see that this is the same criteria as for pregnant women, with the exception of there's a difference in time frame. In this flowchart, you'll see that the time frame for this group is only 2 weeks. If the patient meets the exposure criteria, then determine if the patient displays symptoms consistent with Zika. This chart also differs from the pregnant women flowchart because the group is not eligible for testing if they're asymptomatic. Note that non-pregnant women include those planning to conceive in the near future. These patients should be counseled on time frames to wait before trying to conceive after exposure. This will be discussed later on. Now looking back at the chart, then only those that are symptomatic, as I said before, should be approved for testing. A key item on this chart is the recommendation that all individuals, regardless of approval status, should receive counseling. You should advise the practitioner to counsel the patient on sexual transmission and mosquito prevention. Also make sure the patient is counseled on wait times before attempting conception. Next, I'd like to introduce to you Sonia Frunton. She's another regional epidemiologist, and she will review collecting information as well as counseling the provider.
Good morning. I will begin by discussing the purpose of the Zika virus patient information worksheet. This worksheet is necessary to obtain information to consider or approve Zika virus testing for an individual. Updated NJ-DOH testing criteria can be found on the link below at nj.gov, and determination of whether the country to which an individual traveled is experiencing Zika transmission can also be found at the cdc.gov link listed below. The form is available to assist local health departments in collecting information. This form is for local health department use only and for SRD/CDRSS completion. Once information is collected, it can be shredded or stored in accordance to your local health department record retention policy. So the following is the most updated version of our Zika virus disease patient information worksheet. It was updated this month, July 2012. This worksheet is included in handouts within this webinar, and we'll go through different sections of this worksheet. The first section is patient demographics. At the top, you'll see the CDRSS number, which is optional. Following, we will need the patient name, patient date of birth, patient sex, patient address, patient phone number. And as I mentioned below, the CDRSS's inclusion is optional if the LHD will be keeping a paper record of the intake sheet. Following, we'll be reviewing the travel history and pregnancy status within the information worksheet. Travel location with dates and departure dates must be collected with the exact dates of travel and the country that they're traveled to. Make sure you check the appropriate travel locations, exact dates, and verify that the case is within the appropriate time frame for testing. Within the other exposure section, here you will indicate if there are any other types of exposure. If the physician is suspicious of any other types of exposure, this should be indicated in this box. If the patient is pregnant, be sure to indicate by using yes or no. It is also very important that we have the estimated date of delivery for the patient, and if applicable, the last ultrasound date, and if there are any concerns or if the ultrasound was normal. Next is symptom status / signs and symptoms. Here you would indicate if the case is either currently symptomatic, recovered, or formerly symptomatic, or asymptomatic. You also want to indicate if the case remembers reporting any mosquito bites while traveling, and if the case is symptomatic, there are a list of signs and symptoms that we would want you to review. These include fever, rash, conjunctivitis, and joint pain. When assessing symptoms, be sure to get an actual temperature of the fever if possible, if fever is present, as well as the type and distribution of rash if a rash is present as well. Be sure to list all additional symptoms if not listed, and be sure to also include all onset dates, as well as resolution dates if applicable. Next, we'd be looking at conditions, immunization history, disease background, and additional testing. First, we'd want to understand if the person has any conditions or complications that we should know about. We'd also need to know about immunization history and the year of immunization if possible. These include particularly yellow fever vaccine, Japanese encephalitis vaccine, tick-borne encephalitis vaccine, and the year if at all possible. The traveler may be able to recall having a yellow fever immunization card or a yellow immunization card to get these records. Also be sure to get previous history of flavivirus or arboviral disease such as West Nile virus, dengue virus, chikungunya virus, or Powassan virus and the year, as well as any other flavivirus or arboviral diseases. These may include St. Louis encephalitis, California encephalitis, as well as Eastern equine encephalitis. Be sure to collect accurate information on any of the previous disease history or immunization history as well, as this is used to interpret lab results. If the case is symptomatic and fits the clinical picture of any other diseases that may be arboviral in nature, such as chikungunya or dengue fever, be sure to make a recommendation for testing for those tests that can be done commercially with the associated travel. For submitter information, you'd want to make sure you collect the healthcare provider name, the medical record number, also known as a patient ID number, the institution with which the provider is affiliated with, the address, phone number, fax, email, and a point of contact if it's not the provider. Most importantly, please make sure you collect a correct and accurate fax number, as this will be used to send lab results to providers. This fax number is mandatory. Next, we will be reviewing provider counseling. Provider counseling can be done by phone if the provider calls, and it can be provided by fax when responding to a fax request. LHDs can also call the respective provider if they choose to do so. So some of the basics of Zika virus and sex are as follows. A man with Zika virus can pass it to his female or male partners during vaginal, anal, or oral mouth-to-penis sex without a condom. Zika can be passed from a man with symptoms to his sex partners before his symptoms start, while he has symptoms, and after his symptoms end. Men with Zika who never develop symptoms may be able to pass the virus on to their sex partners. Zika virus can stay in the semen longer than in the blood, but we don't know exactly how long Zika stays in semen or how long it can be passed to sex partners. There are a couple things that we don't know or are still being investigated. One of them including if a woman with Zika can pass the virus to her partners during vaginal or oral sex. Although in a recent MMR that was released last week, it was documented that there was a single case study of a woman-to-man transmission. This is still being investigated, but at this time, CDC testing criteria remains the same. We also don't know if Zika can be passed through saliva during kissing, or if Zika can be passed to a pregnant woman during sex, if that has a different risk for birth defects than Zika transmitted by just a mosquito bite. As always, the prevention of Zika virus in sex include condoms, which can reduce the chance of getting Zika from sex if used correctly from start to finish every time you have vaginal, anal, or oral sex. And of course, abstinence eliminates the risk of getting Zika from sex altogether. So for prevention of Zika transmission from men and their pregnant partners, these include men who live in or have traveled to an area where Zika is circulating and have a pregnant partner. They should abstain from sexual activity or consistently and correctly use condoms during sex. This could include vaginal intercourse, anal intercourse, fellatio, and this should be done throughout the entire duration of the pregnancy. Pregnant women should speak with their healthcare providers about their male partner's possible exposure to mosquitoes and a history of Zika-like illness. If a man develops symptoms of Zika virus during his travel or within 2 weeks after he returns, he should consult with his healthcare provider. All of this information is also available on the cdc.gov website listed below. For prevention of sexual transmission of Zika virus for men and their non-pregnant partners, the recommendations are pretty much the same as with pregnant partners, which include abstinence as well as correct and consistent use of condom use. But they include that men who have been diagnosed with Zika virus or have symptoms of Zika should consider using condoms or not having sex for at least 6 months after symptoms begin. And men who have not developed symptoms should consider using condoms or not having sex for at least 8 weeks after the man returns. This information is also included at the cdc.gov website link below. Next, we will review the recommended time frame to wait before trying to get pregnant after a possible Zika virus exposure. For women with Zika symptoms, they should wait at least 8 weeks after their symptoms have started. For men who have Zika symptoms, they should wait at least 6 months after symptoms have started. For women with no Zika symptoms, wait at least 8 weeks after your last exposure. And for men with no Zika symptoms, wait at least 8 weeks after your exposure, and be sure to talk with your healthcare provider. And as we have mentioned before, possible Zika virus exposure includes travel to or residence in an active area of Zika virus transmission, or sex, which includes vaginal, anal, or fellatio, without a condom, and a man who has traveled to or resided in an area with active Zika transmission. So next we're going to talk about specimen collection for newborns indicated for Zika virus testing. Once the LHD is advised of any of these newborn cases, they should collect as much information on the mother as possible and call the Communicable Disease Service, who will work with the provider in the coordination of these specimens. Specimen collection on these newborns should be done if the mother has a lab confirming or suggesting Zika or exposure with an infant anomaly. These infants, which are also known as possible congenital Zika virus cases, should be reported to the New Jersey Department of Health as soon as possible. The specimens that we look for in these cases include, at the time of delivery, providers should collect cord blood, spun down to serum and stored like serum, label the baby's information and clearly label cord blood. Placental and umbilical cord tissue should also be collected in fixed formalin, several pieces, fresh frozen, several pieces. These pieces of tissue must be labeled with the mother's name. And before the newborn is discharged from the facility, please be sure to collect serum and urine from the newborn. All specimens need patient name, date of birth, specimen type, date, and time of collection. For local mosquito prevention, all travelers, both symptomatic and asymptomatic, should take active steps to prevent mosquito bites for 3 weeks after they leave an area with active Zika transmission or have had an unprotected sexual exposure. For further information on the prevention of mosquito bites, please be sure to see the CDC link posted below for Zika prevention strategies. Next, we will be reviewing creating a CDRSS case approval number with Julia Wells, our regional epidemiologist.
Thank you, Sonia. Good morning, everyone. So now we'll move on to entering your Zika testing request into CDRSS. This serves several purposes. First of all, it allows for a centralized location for both you as the local health department and for CDS to track and monitor testing requests and results as they are received. Secondly, you will need the CDRSS case ID number to create the unique approval number that is entered onto the SRD1 form that you'll fill out in the next step. Finally, since Zika is a nationally notifiable condition, if your person under investigation, or PUI for Zika, winds up needing case definition, you will already have the essential clinical, laboratory, and epi notes in the case. And this is really not much different from entering any other case into CDRSS. There's just a couple of quirks that we need to point out and a couple of really essential things that you need to have your eye out for. And the most crucial thing really is that the CDRSS case ID will be used to generate that SRD1 form. So the first thing you should do, because there will be a slight transition for providers who are requesting Zika virus testing to the appropriate local health department, and many of the area's larger OBGYN practices and maternal fetal medicine practices have a large catchment area. Like any case you are entering, you should do a quick search to ensure that one of your public health partners hasn't already approved this individual for testing. You can either do a quick lookup with last name and disease name Zika, or do a person search, which you'll need to do anyway when you enter the case. And this will prevent you from creating two person IDs and winding up with cases that you have to merge. So now we'll quickly go tab by tab. All of your typical tabs that you see in the CDRSS case here are listed, and the ones that underlined are the ones that we're going to focus on today. In the patient information tab, nothing really out of the ordinary on this tab. Just make sure that patient address and contact information are entered correctly. If when you are receiving the request from a healthcare provider, it's noted that the person is, if this is primarily important for pregnant women who are being requested to have Zika virus testing, if they are not a resident of the United States, note the country of residence in that patient info tab. And this will be important if the woman winds up entering the CDC pregnancy registry. In the address tab, as I spoke about earlier, if you do need to add an international address, you can add it here in the address tab. But the primary address should be the local address in New Jersey where the person is residing. Moving on to the clinical status tab, this is where a large portion of the information you gathered during your initial consult will be recorded, including illness onset date, if applicable, if the person was symptomatic, pregnancy status, and provider information. And we'll take a look at these further on the next slide. So where your yellow arrows are, your illness onset date, if you didn't record it in the patient information tab, you're going to record it in the clinical status tab, or sorry, the clinical information tab. If like many CDRSS cases, your pregnancy information will kind of default. If it's a male, it won't be available for you, but for women of childbearing age, that indicator should be up there, pre-populated based on birth date and sex, and you need to check off pregnancy status for every case where that is applicable. If the person is pregnant, you must add the estimated delivery date. As you've been seeing Zika virus testing approvals that have come through, there are a lot of other dates that are associated. There's gestational age at illness onset, gestational age at travel, but all of these can be calculated from the estimated delivery date, so it's really essential to put that date in the appropriate field. And then also your physician information, your ordering provider. My colleagues emphasized how important this was when you're gathering information so that if additional specimens are needed and results can be communicated to the appropriate provider, this is where you're going to enter them on the clinical status tab. You're going to enter the ordering physician, a phone number for questions and follow-up, a fax number for results. If this testing request came from an acute care facility, if the patient is inpatient or was seen in the ED, you'll also want to add new medical facility. You'll want to add the appropriate ordering medical facility and hospital information, discharge dates, and such. You will also note where there's a large yellow X in the initial diagnosis field, the NJZ number. We are now moving on July 20th. We will be creating a new approval number format. CDS will be using this as well. So no need to enter anything into that tab starting July 20th. But if you are working in cases that have previously been created by CDS, please leave that number there. You don't need to change it. Moving on to signs and symptoms. Again, one of the really crucial parts of your CDRSS case entry. Like all diseases, please check off all symptoms and applicable onset dates. As my colleagues mentioned again, please check off Zika-compatible symptoms, but do add other symptoms that are observed during acute illness as well if you know about them. And keep in mind that onset dates may be different for different symptoms, so where they're different, you can add those. Add resolution dates if they are known. And the attribute, for example, if you're checking off fever, you may want to add the attribute if you have a measured temperature, 102.2 or whatever the temperature may be. Moving on to the risk factor tab. This is the third really crucial tab to gather the information or to record the information that you gathered on your patient information sheet. So there's an overview. What you see now is the overview of risk factors, and then we're going to go through them individually. Location and dates of travel. Both dates, departure and return, are required. That's why you have two date fields next to that risk factor. If the PUI was or is a resident of a different country, indicate this by putting the arrival date in the second date box, as you see below, and note in the comments. If the PUI has multiple travel dates, put the most recent in the travel field and note additional dates and locations in the comment field. So you can see the example on your screen is someone who is living in Jamaica for, if this was a pregnant individual, and that's the example we tend to use, it's usually the most complex. This is someone who is living in Jamaica, far in beyond before conception and is just visiting the United States. So we do not put anything in the first date field, and we put the entrance into the United States on June 18th into the second date field. If this was someone who was a resident of New Jersey just visiting Jamaica, you could put 6/11 in the first date field and 6/18 in the second one if someone just went to visit for a week. Did symptoms occur? This is one of the risk factors that's not totally intuitive. Unlike other risk factors where you only check the box if the answer is yes, this risk factor must be checked for every PUI that you enter into CDRSS. So every quote-unquote case of Zika that you enter in CDRSS must have symptoms occurred checked off. And there are 3 choices that you will select from. Again, this attribute has to be, so one of the 3 has to be selected for every person that you enter. Either currently symptomatic within 2 weeks of exposure, ever symptomatic during or within 2 weeks of exposure. So this is someone who was symptomatic acutely but has since recovered, or asymptomatic, never had symptoms. And again, you can put the appropriate date in there, but you already did capture it in the illness onset date, so it's not essential. Was the patient exposed to mosquitoes? This risk factor should be checked off only if yes. No attribute or dates are needed. If you wish, and if the person denied having mosquito bites, you can note this in the comment box saying patient denied mosquito bites while traveling. If travel and mosquito transmission, our most common route of transmission, is not what is being suspected by the ordering provider, this is in the next risk factor is non-mosquito transmission suspected. This is where you're going to check this off. If you're suspecting congenital transmission in a neonate, sexual transmission, if it's not clear-cut, blood transfusion or organ transplant, laboratory exposure, or some other novel route of transmission. And again, these are the situations where you're going to want to call your regional epidemiologist for additional guidance, but you can note this in the case preliminarily. Moving on to the laboratory tab, in general, you can leave this blank when you're entering a CDRSS case, and you can check back here for results as they are received and either entered by one of us at CDS or entered electronically by our public health laboratories. Contact tracing, also unlikely to be used, but may be used in 2 circumstances where, again, you'll probably be in consultation with CDS. The first of which would be vertical transmission. If both the mother and the neonate have cases in CDRSS, you can link them, much like you would do with a perinatal hepatitis B case, or in cases of sexual transmission, if both individuals have been approved for testing. And again, we can walk you through this if this case occurs. It's not the large majority of the cases that we are approved, but that could change. Epidemiology tab, you can also leave blank. And finally, in case comments, this is the place to record additional notes on progression of pregnancy, such as dates of ultrasounds performed and the results of those ultrasounds. We always want the most recent ultrasound if possible. History of vaccination and prior flavivirus infection. Those were the vaccines that Sonia talked about. And notes on lab results received, requests for convalescent testing, or any other notes about the ordering provider or the case. And up here you can see an example of some of the comments that you might put in. Denies travel vaccine, denies history of flavivirus infection, and some notes about that you might have recorded in the prior tab about where the person was living before testing. And then the last note you'll see is one on prior ultrasound. So moving on to case classification, all PUI reports entered by a regional epi will be put in as a default to report under investigation pending. For the time being, please designate all PUIs as report under investigation, and the report status should be left in pending or LHD open per your preference. Currently, CDS is managing case classification and case closure. We will keep you posted if changes are made to this process, as well as in circumstances where local health department assisted is needed in case follow-up. And so, final step, after you've submitted your case, you should now have your 7-digit CDRSS, well, currently 7 digits, we've got a while to go till we hit 8 digits, your current 7-digit CDRSS ID number. To move on, add the letters NJZ to the CDRSS case ID to create the unique approval number that is entered onto the SRD1 form. Make sure to record this number for the next step of the process which is the completion of the SRD1 form. Your regional epidemiologist, Diana Lucas, will now walk you through that process.
Thank you, Julia. Good morning, everyone. I am going to go over with you the SRD1 form. You probably have seen this form before. Cell uses it for all viral specimens. Basically, why do we need this form? After using the unique approval number, you're going to enter that on the SRD1, and that's going to be used as the approval form. The form is going to be given to the patient, sent to the provider by you, and given to the patient from the provider, and then the patient will bring that with them to the hospital laboratory where they're going to be drawn for testing. The SRD1 form and also a prescription for Zika testing for urine and serum will be given to the patient when they are going to the lab. So once the specimen is collected, the lab will use this form and it will be included in the shipment to Cell. So please make sure you keep a hard copy, whether it's electronic or paper form, in case we have any questions. I'll go over individually each section of the SRD1 form. Cell just recently updated the SRD1 form. It can be found on nj.gov under our forms section. The form now includes Zika testing as an option under molecular and PCR testing. The form is sort of better laid out for entering, tabbing through the form, and you can enter electronically. And then also includes a spot for urine and more space for the provider information. So let's go through each section and discuss what we'll need to fill out for Zika testing specifically. The first section is the demographic information. You're going to see you want to put last name first, a first name, address, city, and state. Sometimes it's not going to be New Jersey, so we want to make sure to have that state in there. At the very top, the CDS case number is going to be the unique approval number that Julia had just discussed. So it's going to be NJZ and then the 7-digit CDRSS number. We'll discuss the specimen collection as well on the next slide. Basically, the specimen collection section should be left blank, but on specimen type, you can go ahead and select serum and urine. These are the preferred specimens, and you can check that off before sending to the provider. This section is the most critical piece of the form. The onset date is for individuals who are symptomatic, but for the pertinent clinical information, we need to have all of these, all of the portions of this form for Cell may reject the specimen if you don't have everything included. So we want to make sure that they are symptomatic or asymptomatic. You have to note whether they're asymptomatic and also the symptoms if they are symptomatic. If they're pregnant or not pregnant, the country of travel and the dates of travel. If there's a novel route of transmission, sexual transmission, or any symptoms experienced, as I said before, and an estimated due date if the person is pregnant. Additionally, we want to have the history of arbovirus and flavivirus disease or vaccine information in there as well. So just to emphasize the importance of the section, I wanted to give you sort of a few examples. Most of these, all of these examples are for women. We want to say asymptomatic and pregnant or not pregnant. With travel to the Dominican Republic, say, and from June 7th to June 12th, the woman has an estimated due date of 1/30/17 and a prior history of West Nile virus in 2011. An additional example we could use is a symptomatic individual. She's not pregnant, or it could be a male, but you don't have to note that they're not pregnant as long as you check off in the gender section, whether it's male or female. The person had traveled to Argentina in July and had developed symptoms of rash on face, fever of 101, and diarrhea. And you want to be as specific as possible with the symptoms and include no vaccine or disease history. Lastly, you can use an asymptomatic and pregnant, unprotected sexual contact with husband who had traveled. So we need to spell out sort of what the exposure is there, and that's sexual contact in this scenario. They traveled in May and developed a fever only 2 days after returning. The estimated due date is 8/26/16, and they did have prior yellow fever vaccine. So we want to fit as much information in there as possible. Sometimes you're going to have to use a shortened version of, you can put history as HX or however you see fit, but make sure that, you know, FEL can understand exactly what you're putting in there. In the next section, you can check off Zika testing before sending to the provider. That's all that you need to do in this section. And at the end of the form, you're going to enter the requesting physician information. The submitting facility information portion should be left blank. That will be completed by the hospital laboratory that's submitting the specimen. For the requesting physician information, we need the physician name, and also under address, you would put the name of the facility and also the physical address. If there's a contact person who is calling who would request the results, once they are received, you can put that in the contact name if it's different than the physician. Also, we need a telephone number and specifically a fax number. Whether you're planning on faxing or emailing the form, we must have a fax number to send results to, so that's important to know. An email address if possible, and in the patient ID field, you can put in a medical record number if the facility gives that to you. So once the SRD1 form is completed, we will go ahead and send it to the provider. So you can do so by fax or by encrypted email. Along with the SRD1 form, we created a fax cover sheet with some prevention information for both sexual transmission and mosquito transmission in preventing mosquito bites while ill. It also gives the provider a guide as to what to provide for testing, including Zika script for serum and urine, also the SRD1 approval form, and the NJDOH FEL technical bulletin. So make sure to fax all that information together. And on this fax cover in red, you can see that you should update where your local health department phone number is and also the name of your health department. And so this is the technical bulletin. Questions on shipping can be directed to FEL at zika.fel@doh.nj.gov. But this should give you a general idea and also the laboratory a good idea of any questions that have come up recently in the FAQ, and as well as information on shipping and storing. The FEL technical bulletin was just updated last week, so please make sure you include the latest version with every fax. So next up is Courtney Kirkland. She's going to talk about some scenarios with you.
Hi. Since we all have reviewed the guidance and are well versed in the process, let's move forward with an interactive session in which I'll provide a scenario and you will provide a response via a poll. The answers will populate on the screen and you will choose an answer. After the vote, I will provide the correct answer and also some feedback. This will be a great time to reference your Zika approval flowchart that Maisha discussed earlier, and also a calendar to review dates. Okay, so the first scenario. You have a provider that calls with an asymptomatic, non-pregnant woman who traveled to the Dominican Republic last week for her honeymoon. The patient is back in New Jersey and is currently trying to conceive. Would this patient be approved for testing? Give me 1 second. Okay, would this patient be approved for testing? Yes, because it has been less than 8 weeks since she returned back to New Jersey. Number 2, no, because she is not currently pregnant. Number 3, no, because she is asymptomatic. Or number 4, both answers 2 and 3. Okay. So the answer for this would be number 4. The patient is not currently pregnant and she's not symptomatic. It's a key point to remember that only individuals who are actively trying to conceive with travel history do not fit the criteria for testing. Only pregnant women who traveled during the 8 weeks before conception or at any time during their pregnancy, or non-pregnant women with at least one Zika-compatible symptom with travel history are eligible for testing. Okay, so we're going to move forward with the second scenario. We have a provider that calls with an asymptomatic pregnant woman who moved to New Jersey from Dominican Republic yesterday. So how long should this patient wait to have her specimens collected? Should it be any time between 2 to 12 weeks after the last exposure? Should it be the specimens could be collected at any time? Or should it be within the first 7 days after exposure? Okay, so the majority of you got it right. It is number 1, anytime between 2 to 12 weeks after the last exposure. So preferred specimen collection times for asymptomatic pregnant women is between 2 to 12 weeks after travel. We expect that antibodies will be present from 2 weeks after viral exposure and could persist up to 12 weeks and eventually wane off. The next scenario. Number 3. Okay, scenario number 3. A provider calls with an asymptomatic pregnant woman with travel history to Haiti between January 7th through January 18th. The patient conceived while in Haiti and also reports mosquito exposure. Would this patient be approved for testing? No, because it has been longer than 12 weeks since travel to an affected area with Zika transmission. Yes, because she conceived while in Haiti. Or yes, because she reported mosquito exposure. Okay, so the answer for this is no. It has been longer than 12 weeks since travel to an affected area with Zika transmission. It's a key note to remember that testing can only be performed 2 to 12 weeks post-travel for pregnant women. If it falls outside that time frame, serial ultrasound should be recommended. If an anomaly is detected, the provider should contact public health at that time. The next scenario. A provider calls you with a symptomatic pregnant woman who returned from Puerto Rico 2 days ago. The patient delivered an infant with microcephaly and the provider suspects Zika. What would you do in that situation? Would you, 1, request provider collect cord blood, umbilical cord, and placenta samples? Or would you inform the provider that samples cannot be submitted until appropriate paperwork and approvals are completed? Would you report to New Jersey Department of Health? Or would you all of the above? Okay, so the answer is all of the above. Note that this is very highly unlikely, but if you receive a call from a provider or delivery doctor saying that there's a baby being born or was just born to a mother with 1, confirmed Zika or lab suggestive of Zika, or if the infant is born with microcephaly and the provider suspects Zika, please notify us as soon as possible so that we can follow up with the provider. If the provider wants immediate guidance, please request that they freeze cord blood, umbilical cord, and placenta samples from the infant. If the mother has not already been tested for Zika, the provider should also collect urine and serum specimens for her as well. Please emphasize that providers cannot submit any samples until the appropriate paperwork and approvals are completed. However, if the mother had no prenatal care or has a pending lab test, but the baby is healthy and asymptomatic, the provider can treat it as a normal delivery. All right, so we have scenario number 5. A provider calls with a pregnant asymptomatic woman who recently traveled to Florida between June 26th to June 31st. The patient reports mosquito exposure. Would this patient be approved for testing? Yes. The patient traveled to an area with positive Zika cases? Yes, but the patient has to wait 2 weeks post-travel before having specimens collected? Or no, the patient did not travel to an area with active Zika transmission? So the response with this would be, actually no, the patient did not travel to an area with active Zika transmission. A key point is to remember to check the CDC list of affected areas before approving cases. If you have any type of questions, or if there are countries that are not on the list, such as Thailand, Cambodia, or the Bahamas, that you just want to consult with your regional EPI with, just feel free to give us a call. We can talk through those situations. The next scenario is a provider that calls with an asymptomatic pregnant woman who recently had unprotected sex with a partner who traveled to Mexico 2 weeks ago. The partner was currently experiencing nausea, vomiting, and diarrhea. Would this patient be approved for testing? 1, yes, the partner and the patient should be tested since there is a risk of sexual transmission. Or, yes, the patient should be tested since she is currently pregnant. Or number 3, no, since the partner is not experiencing Zika-compatible symptoms. Okay, so the response to this would be no. Since the partner is not experiencing Zika-compatible symptoms, the patient would not need to be tested. Although the partner was experiencing symptoms, they were not an indication of a Zika infection, which are rash, conjunctivitis, and rash and joint pain. The criteria for testing for pregnant women include those who report unprotected sex with their partner who has been diagnosed with Zika or who has Zika-compatible symptoms and travel history. The last scenario is you have a provider that calls with an asymptomatic pregnant woman with travel history to Brazil. The patient returned to New Jersey on June 10th and conceived 6 weeks later. This will be a good time to pull out your calendar just to review some of the dates. So would this patient be approved for testing? No, she was not pregnant while in Brazil. Yes, her last exposure in Brazil is within 8 weeks. Or no, she is asymptomatic. Oh, very good. 91% got this right. So the answer is number 2, yes. The last exposure in Brazil is less than 8 weeks, so she would fit the criteria for testing. The patient became pregnant 6 weeks after her last exposure, which will be the last day in Brazil. It's important to remember that pregnant women who during the 8 weeks before conception or at any time during their current pregnancy with travel history to an affected area are eligible for testing. So at this time, we'll have Maisha Brace back, and she's going to go over some Zika testing resources.
So I decided to give you a few resources that you can use in the testing approval process. So the first set of resources are New Jersey Department of Health Zika information. You can go to New Jersey Department of Health Communicable Disease Zika page, which I have a link here, and it contains the latest general and technical info about Zika testing, as well as other just information about Zika virus in general. Next one is about it'll help you in the approval process. So I've given you a link to the Zika affected areas, the pregnancy calculator, which can be used for determining the EDD for providers that may not already have that, or they're not a OBGYN practice, so they're not, usually calculating that. So this source here, you can actually put in the last menstrual period date, and it can give you the expected delivery date. That'll also be important in, the Zika testing process. The last one is counseling for travelers, and that's just general information that you can provide to travelers who either are going to travel or who have already traveled in the prevention of Zika virus transmission. And then there is laboratory information. So you can go to our FEL technical bulletin or the FEL website, which I've provided a link here, as well as you can go to our New Jersey Department of Health website that will also give you information on the number of Zika case counts in the state of New Jersey. And the link there, and it will take you directly to the case counts. And then one of the last set of resources are regarding Zika and pregnancy. So there's the first link is for pregnant women who have a history of travel, and it's just information. It'll take you to infographics from the CDC that you can share with pregnant women who travel that gives more information. And then there's information on our on the CDC's Zika pregnancy registry. So that'll take you to information about the registry, what it's about, how to sign up, and such. So next I'll introduce to you Kara Plott. She's our acting vector-borne disease team lead, and she will give you some updates from New Jersey Department of Health on Zika.
Hi everyone, thank you and good morning. I just want to acknowledge that we're really aware of how active everyone's been in your own jurisdictions, providing presentations, prevention messages, and different events to inform the public about Zika and how to prevent it. And we know many of you have been eager to assist us in more of the Zika procedures. There's definitely been a lot of changes to the approval protocol over time, and we're finally very happy to have this systematic process that we think can be the base for the foreseeable future. Just so you know, this has been what the regional epidemiologists have been doing pretty consistently for the past 2.5 months with success. So we now we think it's time to roll it out, and we want to say how excited we are for you to step into this role and assist us. The approval process seems a little unique, but I think as Julia mentioned, it's really the same as conducting the disease investigation. And we're conducting that investigation just prior to the laboratory results. So you'll have all of the information. I know that some of you may have noticed some commercial laboratories doing testing. That is happening. They're able to attest acutely ill individuals with a PCR test. And on a positive test from a commercial lab, we won't have that entire disease investigation background. So you will be responsible in doing those investigations. And the ones that have been investigated so far, we're really impressed and pleased with, so thank you. We actually hope that the materials today you'll find useful for doing those disease investigations because it's the same information that you'll need to collect whether we knew about the person in advance or whether we're learning about the person in the future. I think the key thing is the ability to do some of these investigations in advance make our lives a lot easier in a way because we know for sure that this person meets eligibility. And that's one of the reasons that we need these forms filled out so carefully. The lab testing is still really complicated, and a lot of the types of tests involve the dates of travel, exposure, and symptoms to determine what type of laboratory results get done. So all of the information that we request is actually used by the laboratory and is used when we interpret the test results. So although these approvals have been pretty systematic the last 2.5 months, one thing that has not been systematic is the results interpretation and the case classification. So this has remained a little in flux, and we learn more about Zika. It's a really interesting arbovirus, and as we learn more and we learn more about how great or not great lab results are, we're able to adjust how we classify and confirm cases. So we'll talk more about this at the quarterly Communicable Disease Forum webinar. My colleague Karen Worthington will be speaking for the Zika team. But for now, just know that our Zika team will continue to classify and close cases, contact providers about positives, and or request any follow-up specimens as needed. The testing is somewhat complicated. Sometimes multiple tests need to be conducted on the same specimen, and sometimes more specimens are needed based on the timing that the specimen was collected. So just when you're looking at CDRSS, one negative doesn't always mean a negative. There might be more tests coming down the pipeline. So please don't close out cases. We'll continue to do that. You won't be responsible at this point. The changes are coming very rapidly, so we just don't have anything concrete as far as guidance to give you other than we'll keep doing that closeout for everyone. And so just know that still will remain our responsibility, but thank you all for being on top of your cases in your jurisdiction. But in sum, we're really excited for you to join us. Please contact your regional epidemiologist for questions, and know we're all available to assist with any unique circumstances that come up. So, please don't hesitate to reach out. I think we're going to head to some question and answers now. Some of you have been typing in questions, so I'll give that over to Maisha, but I'll also be here to assist any questions. Thank you, guys.
This is Maisha Burks again. Before we go into actually answering questions, then I would like to remind you of our upcoming Summer Communicable Disease Forum webinar, which will happen on July 28th from 9:30 a.m. to 11:30 a.m. Please go to NJLMN to register. Also, for the slideshow today, it was actually recorded, so this webinar was recorded, and it will be posted on our website, so where you can review later to see the slideshow again, as well as the slides will also be emailed out by your regional epidemiologist and also posted on the NJLMN website under Practice Exchange. So we're going to get ready to set up for our question and answer session. We have to move around a little bit.
This is Kara. Just to answer, we have a question, why can't physicians do the approval? It seems a lot of back and forth. And that is a good question. I think the main answer is there's still very specific criteria on who is truly exposed and who is truly eligible for testing. And that exposure information really needs to get to the laboratory appropriately. And there are still some lab capacity. Just as you know, commercial labs can only do very small amounts of testing, PCR. The serology testing is still really only available through public health labs. So we want to make sure that the people that we use our resources for are actually eligible and that we'll actually have a meaningful lab result come out of the testing. So that's why we'll rely on our local health department partners to make sure that the true criteria are met before submitting a lab result. Also to make sure that those lab forms get filled out with the information our lab really needs to be able to determine which tests are best preferred. A second question, just working with providers. We've been doing this here at the state and the regional epidemiologists. The providers want this testing. They're pretty aware it's a hot topic. So we don't think there'll be a lot of issues working with providers. They'll be calling you for those testing approvals, and they're interested in the state testing because of the serology component. Do all New Jersey hospitals know they are to do Zika testing, or will we get calls of patients being turned away? Again, we have been doing this. The hospitals have been laboratories have been working closely with FEL, our public health laboratory. So we don't believe that there are very many issues anymore. They should anticipate this. They'll look for an NJZ number in that SRD1 form, or they'll give us a call. So please make sure that's filled out, and we'll do any follow-up. If you do have a concern, let us know, but we do think that they're expecting, they've been doing it pretty routinely now, and we think most of their questions have been answered. Is there any funding for LHDs like in Ebola? No, this is considered part of a disease investigation, and so it's part of what local health departments are responsible for doing. And how available will the state epi staff be? Just like always, our regional epidemiologists will get back to you as soon as possible. We're available on the Zika team. Just so you know, there can be a lag time between when you get that ordering form out if you talk to providers. especially the asymptomatic pregnant women, because they have 2 to 12 weeks to get that testing done. So we would say if you have to prioritize anyone, to prioritize getting the SRD1 form to providers with currently symptomatic patients, or with a pregnant woman right at the end of her 12 weeks, because she needs that blood drawn as soon as possible. So that would be maybe a suggestion for priority.
So one of the next questions is, if a pregnant woman travels to an area, Zika-affected area, but does not have any symptoms or report mosquito bites, should she be tested? Yes, that woman would be tested. Any woman that has traveled to a Zika-affected area within the past 2 to 12 weeks, or within the past 12 weeks, and returned, whether she conceived there or if she traveled there while pregnant, then she will be tested.
Regarding time frame for avoiding mosquito bites, some of the guidance says if the person is symptomatic, avoid bites for 7 days after onset, and if someone's not symptomatic, avoid for 3 weeks. That's a great question, and we want to kind of give a consistent message, and so we ask that for 3 weeks since exposure, so returning from travel, that everyone from a Zika-affected area or other areas with mosquito-borne viruses really try hard to prevent a local New Jersey mosquito from biting them. Our biggest concern with using the 7 days from symptom onset, while that's accurate if we know for sure it's the disease, we're concerned what if someone just has a fever and it's really because they have the flu and they're in the incubation period and actually develop true infection maybe a week later? Or what if they're co-infected with dengue or chikungunya? So we would like just to keep the messaging simple and say for 3 weeks from returning from tropical areas, from areas with Zika, widespread Zika transmission, 3 weeks from exposure we think is a standard messaging. Okay. What if you determine testing should not be approved based on criteria and the patient turns out positive? Who is liable? If the person's not approved, I don't know if we could determine how they, I don't know how we would know if they were positive. If not, if we're speaking of pregnant women who don't meet criteria and maybe later there seems to be a problem with the fetus that indicates perhaps there was an exposure, there shouldn't be a liability issue. Any woman who travels to a Zika-affected area should still be observed more closely throughout their pregnancy for symptoms or for congenital issues to develop. Regardless of the test. Just I think it might even be worse to send a woman post 12 weeks and have them have a false sense of security when their test comes back negative because the antibody test doesn't pick up an antibody 12 weeks. Post 12 weeks it begins to wane in the system. So I think it's more important to follow the criteria and the guidance. Those are the official laboratory criteria, and we'll stick to them, and that's the guidance from our laboratory, which we follow.
One question is regarding the FEL technical bulletin. Does the patient need to take the second page with them to the lab? Yes, the patient does need to take the second page of the FEL technical bulletin. Although many of our labs have already drawn specimens for Zika testing, it still provides step-by-step guidance to follow in order to collect the specimens, package them, and ship them properly.
The lab turnaround time can be found on the FEL technical bulletins. There was a new one that was released last week, so a July update, and they have different turnaround times. I'm sorry, I don't have it in front of me, but it will be posted to the technical tab of the NJDOH Zika page, and again, you may have received copies of that. So you often use the acronym TAT for turnaround time, so please be sure to look at the FEL guidance for turnaround time expectations.
So do you need separate SRD1 forms for urine and serum samples? No, you will not need separate SRD1 forms. You would actually check off the boxes that Diana talked about to collect the urine and then also collect serum samples. So it'll all be on one SRD1 form.
Great. And I also want to point out that serum alone will be tested, but if someone sends in a urine sample without an accompanying blood sample, it will be rejected. So just make sure to emphasize that urine by itself doesn't meet the FDA emergency use authorization, so will not be tested alone. Any non-blood specimen needs an accompanying blood specimen drawn the same day. Are physicians aware that they need to contact local health departments with possible Zika cases, and are they educated with the same criteria we are? The criteria is published to links and is available on our website. We are also planning to send out another links memo today or tomorrow to physicians. We're also hoping, we certainly see some providers who tend to be more likely to submit individuals. Perhaps they have populations that travel for work or family purposes more often. And we're going to be requesting, we're going to try to fax to those providers the links message also. So as you at the local levels might be aware of some practices and have good communication with your partners who are providers, so we'll be certain to forward the links message you get to them. We'll be certain to forward it, and we will also be trying to fax some of the providers we think more likely. And all of our new messaging will say, please contact the local health department. So we'll be referring to you as of July 20th.
So one question is, will the hospital be delivering the specimen to FEL, or is the local health department responsible? So in this case, the hospital will be the ones that are responsible for delivering the specimen. That's part of the reason why we're using the hospital labs, because they're familiar with the packaging and the shipping of specimens to FEL. So yes, the hospitals will be delivering the specimens, not the local health department.
Okay. How is the public going to know when to be tested, and how are they going to be educated? We think this information is pretty public, but really we're hoping providers know that. This is something, if you get a call from a patient, we really encourage you to send them to their provider and have their provider contact us for approval. So the criteria, again, is fairly available, and I do think people seem somewhat aware, but again, it should be something coordinated and organized through a medical provider.
Does the local health department have final say on testing approval, or does New Jersey Department of Health have the ability to override local health departments' decisions? So the local health departments will be, there's the basic criteria that the local health department will be covering, which is what we talked about in this webinar. So if it's anything outside of that, then you would just refer them to New Jersey Department of Health, whether it's a special situation or a special case. So basically anything that you're approving, we should be able to stand by just because it will follow that criteria. But if there's anything questionable, then you should call us.
There's some, for example, there's some new information out about endemic areas where outbreaks aren't occurring. So we see less disease transmission because of herd immunity. But something like that, give us a call. We might follow up with CDC to see what they recommend. And so there are definitely times when we encourage you to reach out to us, and we might make a call after we consult with either the medical director, Dr. Tanis, the epidemiologist, or with CDC. Let's see. Where do you sign up to get links messages? njlinks.org. We encourage everyone to make sure that they are receiving the links messages, which is the state's health alert network system. njlinks.net. I'm sorry, njlinks.net. Again, njlincs.net. Here's a good question. If the provider is seeking testing during off hours, who's responsible for following up with the patient to ensure that they went for labs? There's definitely gaps between when approvals occur and blood specimens are drawn. Really, that's the provider's responsibility. If you approve a test and provide the provider with the appropriate paperwork, they'll have to be, it's their patient and they're ordering the test, so they'll have to make sure that happens. During after hours, we occasionally get calls. I think the ERs are starting to learn, but you know, there's a lot of staff that move through there. We recommend, if something happens, have them just draw the specimens, and you can do the paperwork during business hours. The laboratories can store that specimen and await testing if the provider really thinks the patient will meet testing criteria. And if they don't, the specimens can be discarded. A question about physicians don't usually offer vector-borne vaccinations. What is the expectations that they will be able to provide this information? That's true. We just would like you to continue to request that providers ask their patients and do appropriate patient history, and that vaccine and prior flavivirus history can be valuable when performing some of the confirmatory testing. So we just really emphasize to providers the importance of trying to get a full patient history. I may have answered this, but we did get who will be evaluating the closure of cases. Labs are very confusing, and again, that is something we'll continue to do on the Zika team here at the state. We are getting calls at hotline whose physicians refuse or do not know or want to get involved with testing. Again, just like any disease, it is an appropriate responsibility of somebody's healthcare provider to order tests for them, and that's the best we can do. We need a provider to recommend the patient for testing, and then we'll have to determine whether the patient meets criteria. If you get patients calling saying, I think I meet criteria, they really have to find a provider who can legally order the testing. So they'll have to refer them, continue to refer them back to a healthcare provider. Here's an epi question. Once exposed to Zika, can you be reinfected? That's not something that's known, but based on other flaviviruses, we expect that there's at least some level of protection conferred for quite a while after initial infection. A couple questions on why can't hospital ID staff do the screening or hospitals do the screening. I have to say, anecdotally, most of our requests are not coming from hospitals. They're coming from obstetricians, primary care providers, urgent care providers. And again, just because the criteria is so specific, our lab capacity is limited. Our resources need to go towards those who definitely meet criteria, and that clinical information has to be accurate on the SRD ones when we really need public health professionals assessing those risk factors. Is 80% still an accurate rate of Zika infection without symptoms? That is still what the literature says, and I'm hopeful that there will be more studies confirming that, but we don't know. And to follow up with that, if only 1 in 5 show symptoms of Zika, why is the guidance different for asymptomatic and symptomatic individuals? So like most flaviviruses, infection tends to be limited and really, especially for Zika, not clinical, not severe. There typically does not tend to be a severe clinical presentation. Symptoms are mild and people recover. So to screen all asymptomatic people who had exposure for a disease where likely they'll never have any negative clinical outcomes or will recover quickly seems, just doesn't seem to be a good use of resources. However, since we determined that there is a connection between pregnant women and the terrible clinical impact on the fetus from a Zika infection, we are willing to screen the asymptomatic pregnant women with an exposure to see if we can get that lab that suggests it was perhaps a Zika infection. So that's why we really differentiate the symptomatic versus the asymptomatic. Most people who travel will not end up with an infection. So just to screen the entire population of travelers without having a real clinical necessity, I think would be a burden on resources. So we want to focus on those most at risk, those with a clinical presentation that we can determine might likely have Zika, and those who are pregnant women who have that potential really negative outcome in an infant. We want to make sure that we do everything we can to attempt to screen them and see if we need to be following them more closely.
So is there available infographics or fact sheets, recommendations for the prevention of Zika transmission? Yes, in the resources links, I actually provided some infographics that you can use, and they're from the CDC, so it's fine for local health departments to go ahead and print those out. And you can share them. Oftentimes when I was doing Zika testing approval, then oftentimes I would send educational information and infographics along with the SRD1 form and other forms, just to be helpful to the provider that they can also give to their patients to give more information. Another question is, what exact website is all of this information on? So if you go to our regular communicable disease website where you would go to for our chapters for all the other conditions, there's actually a Zika virus page where you can actually click on it, and then there's general info, there's technical info, and then there's other info regarding Zika. Another question is on the SRD1 form, is the physician name likely to be the same as the contact name? So on the SRD1 form, there's the provider information. The contact is if you wanted to list someone else as a contact. So for instance, there's been a lot of times where there's been a nurse at the practice that's been like our main person that we've been working with, so they decided to list their name as the contact. So we can call back to that person because they're more familiar with, what's going on in the testing process.
How many requests for testing have we received so far? So we started offering testing late January, and we have approved for testing close to 1,300 approvals since then. I would say we're averaging across the state 40 to 50 a week.
So if I get the gist of this PowerPoint, the basic protocols, the MD calls to inquire, seek approval for a patient, utilize the worksheet to collect the information, then based on eligibility and upon approval, complete the SRD1 form and fax to the MD along with the bulletin. Is there anything missing? Pretty much if you just follow the steps that are outlined. One good thing is actually the outline menu that was included in this presentation. That's like all the steps from A through Z that you would just follow from beginning to end. So definitely, like I said, this presentation will be sent out after our webinar is over by regional EPIs for each jurisdiction. So that would be definitely a key to follow to make sure you're following all the steps.
And this is Kara. I would just recommend anything you collect on that worksheet, really, please make sure that it ends up in CDRSS and on the SRD1 form. And again, the hospital labs are very familiar. We've been using an NJZ approval number in that CDS case ID form on the SRD1. We're now requesting that you create the CDRSS, make that the NJZ, and then include the CDRSS number. And that's a quick way that the hospitals know to look for NJZ numbers. They'll keep seeing that, and we'll be able to quickly identify who the case is and get all of that important clinical information from your entry into CDRSS. Let's see. If a Zika case comes through CDRSS, does that mean it was approved for testing, and what is the protocol to close the test? If a new positive, LabCorp and Quest have been doing PCR testing. So a positive PCR that comes electronically from a commercial lab, and there may be one or two other labs sending paper copies that we're hand entering, the protocol would be to conduct a disease investigation. So just like if you were to get a test for dengue or chikungunya, other arboviruses, you would be responsible for doing a disease investigation so that we could confirm symptoms and exposure. How would we know if mosquitoes in this area have become infected or carriers of Zika? Who is monitoring that site of Zika? Great question. Our partners in Department of Environmental Protection and our county mosquito control agencies, which I'm hoping that you all have made partners with, do testing of local populations of mosquitoes for diseases, and we are able to do some Zika pool testing. Additionally, it would take a very acute provider to recognize some severe symptoms, and perhaps we'd know in a geographic area where other people with confirmed disease are. So again, the potential for local transmission in New Jersey is very low, but as the local health department and as epidemiologists and health officers, please keep it's great to keep an eye on what type of requesting you're getting, and you definitely give us a call. If you have a provider who's very suspicious of Zika and there hasn't been travel, give us a call. That's something we would definitely want to look into, but we'd be really looking for some of those, like more than just one symptom, and it would have to be some of those really key Zika symptoms like the red eyes and the rash or the fever, something like that. But feel free to give us a call.
So one last question.
Can we test an individual with previous history, had not traveled or exposed recently, but recently got one or more Zika symptoms? So the incubation period for Zika is probably only about 7 days, maybe a little bit more. So within 2 weeks of exposure, you would see symptoms develop. So anybody developing symptoms that far out would not be based on a recent exposure, and so we would not expect that to be Zika. However, if someone has symptoms and you know they traveled a few months ago, that might be a key time to ask if they maybe traveled with a partner, and then consider sexual transmission, and your exposure then would not be travel. Your exposure would be that sexual contact. So those are great questions to ask. But no, we would expect to see symptoms within 2 weeks of the initial exposure due to the incubation period.
So in closing, I want to give our reminders again. Don't forget about the CD Forum webinar that will occur on July 28th. Again, register on NJLMN. We'll provide Zika updates there, as well as if there's any general questions from the community or from a provider that the local health departments can't answer, then you can always call the NJPIES line at 1-800-962-1253, and that's 24/7, 365 days a year in any language. Thank you for attending our webinar, and I hope you all have a good afternoon.